want to talk about American medicine. We have a real crisis in our medical care. It's a crisis that's far more profound than I ever imagined when I started to do research full-time on this issue about 3.5 years ago. I had practiced in Appalachia for a couple of years. I was a Robert Wood Johnson Fellow, where I learned my research and statistical skills, and worked as a family doc about 30 or 40 miles north of Boston for 20 years. And as my practice continued, I saw the increasing commercial influence coming into medicine. And in fact, the quality of care that my patients were getting, I thought was getting worse, not better. It was actually Vioxx, learning about Vioxx and Celebrex in the fall of 2001, the truth about what was really going on with these drugs, and how the information about these drugs had been misrepresented in our most trustworthy sources of medical knowledge, that caused me to make this commitment. And I'm going to get back to that issue. But when we think about the problem in medicine, most of us think first about cost. We're now facing double-digit increases in the cost of our healthcare premiums. The United States spends $1.9 trillion on healthcare. That's twice the average of the other industrialized countries, twice as much. And when you correct what we spend for our high per-person GDP, you see that we're spending about $550 billion a year more, on healthcare in the United States. You say, well, we're a wealthy country, and there's not much better that we could spend our money on than healthcare. So let's see what we're getting for our investment. But the cost of healthcare is going up so quickly that it's exceeding the ability of corporations to pay for it and of individuals, so the number of uninsured are going up. So after we look at the cost of healthcare as the problem, then we look at the social justice issue, because we have 45 million Americans without health insurance. Now, we saw all the attention that poor Terri Schiavo got. She dominated our airwaves for 2 weeks with a human, personal, family tragedy. But there are, of our 45 million Americans who are uninsured, there are 18,000 deaths a year because they don't have insurance. That's like a 9/11 tragedy every 2 months. We're the only industrialized country that doesn't have universal health care. The only one and the wealthiest one. So in terms of the social justice, in terms of justice as the opportunity to reach our potential, we are failing to do that in the United States. And when we hear that the last election was determined on the basis of differences in moral values, being whether there should be gay marriage, pro-life or pro-choice, those are the divisive issues in our society. But Americans have decent values that are cohesive, not divisive. 76% of Americans say that health care should be a right, not a privilege. Somewhere between 2/3 and 80% of Americans say that we should have universal coverage, and they're willing to give up their tax cuts to pay for it. 85% of Americans say that the drug companies should not be allowed to charge what the market will bear, and we're the only country that does that. So we're very different. And this issue of social justice is a major issue. The marketplace approach that we've taken to providing medical care has created a situation where there are Americans that are not getting what they need, and this is not what we Americans want. And I think this is a real failure of our political process. So we've got cost, we've got the problems with social justice, but what I want to talk about is the real problem with American medicine, which is the quality issue. And this doesn't get talked about enough. In 2000, Barbara Starfield, who's a university distinguished professor at Johns Hopkins, wrote an article in the Journal of the American Medical Association. And her research showed that out of 13 wealthy countries, the health of Americans ranked 12th. That shocked me as a family doc practicing. I thought we were providing the best health care, but we ranked 12th out of 13th. Well, I didn't quite believe that, and that's when I started to do my own research. So I looked at the data from the World Health Organization, and we found that the World Health Organization developed a measure of health, the health of a population, healthy life expectancy. So it's not just life expectancy, but healthy life expectancy, which takes into account how long we live, and you subtract from it the number of years of illness prorated for the severity of the illness. In terms of healthy life expectancy, Americans rank 22 out of the 22 wealthiest countries. So out of these 22 wealthiest countries, we in the United States are spending twice the average and have the shortest healthy life expectancy. There's a chart in the book, I can't project it up, but if you look at healthy life expectancy on this side of the chart and expenditures here, you see a group, excuse me, a group of 21 nations, and then the United States is all alone out here spending twice the average and having the shortest healthy life expectancy. So you say, well, what is going on here? What is going on? How did this happen? And I think to understand how this is happening in our country and why we're not seeing it for what it is, I think we need to go back and look at the role of medical knowledge in our society, because that's really where this problem starts. There's been a radical transformation in the function of medical knowledge in our society. Before 1980, medical knowledge was primarily a public good. Most clinical trials were were funded by the National Institutes of Health or nonprofit foundations. Academic researchers, quote, snubbed their noses at commercially funded research. They thought that that was beneath their dignity. When President Reagan came in and the small government ethos took over, the funds that were available at the NIH shrank for clinical research, and the drug companies were very happy to step in and lend a helping hand. But nothing much changed. This was in the 80s. Nothing much changed. We got to 1991. About 70% of clinical trials were funded by the drug industry, but still most of that research was being done in universities, where there are checks and balances, where there's an ethos that the researchers participate in the design of the research and have access to all the data and participate in the publication of research. In the 90s, things changed very dramatically, because when we get to 2000, instead of 80% of the commercially funded research being done in universities, we get to 34% of the commercially funded research being done in universities. The rest is being done by for-profit research companies. Now, nothing inherently about that, and nothing inherently unethical about that. It made perfect sense for the drug companies to do it. They can get their research done quicker, with less red tape, and for less money. The problem is that that's allowed the drug companies to have virtual control over the way the research is done, the design of the research, the analysis. So many of the authors who write the articles in the most respected journals, New England Journal of Medicine and Journal of the American Medical Association, many of those authors do not get to see the data from their own studies, except as it's parceled out by the commercial sponsor. So the situation is now coming to the completion of this cycle where the largest commercial research organizations are now being bought up by the advertising agencies, because what's happening is the money that's being committed by the pharmaceutical industry to research is committed in a way that it maximizes the return on investment, not the health of the Americans. And if you're going to maximize the return on investment, then you're going to do research. It's the marketing people that understand what kind of results you need to get from your research so that you can sell the most product. Now, the result of that is, there was an article in JAMA about a couple of years ago that looked at the highest quality research in the best journals. And it showed that the odds of commercially funded research supporting their product are 5 times higher than non-commercially funded research. So it's like we're throwing a die that has 5 sides that says, yes, the drug works, and 1 side that says, no, the drug doesn't work. That's the situation that we're in right now. Now, we've heard about Bextra being recalled yesterday or taken off the market yesterday by the FDA. Bextra is an arthritis drug in the same class as Celebrex and Vioxx, and we all know that Vioxx got taken off the market in September because it increases heart problems. Well, I testified at the FDA advisory committee meeting last February, and the question that I wanted to pose to the FDA is that we will not prevent these further drug debacles until we can answer the following question. Why did American doctors prescribe $7 billion worth of Vioxx, which caused about 100,000 heart attacks and deaths, after Merck and the FDA both knew that Vioxx was more dangerous than naproxen, which is Aleve, that it's no more effective, it does not provide better relief for arthritis symptoms or pain than Aleve, and cost 10 to 20 times as much? Why did the doctors believe that was the right thing to do? We all know about marketing. We know that Merck spent more money marketing Vioxx than Pepsi or Budweiser beer spent in 2000. But why did the doctors think it was the right thing to do? And the answer is, we doctors are taught to turn to certain sources and to accept those sources as legitimate. The article that was published in the New England Journal of Medicine in November of 2000 told doctors that Vioxx is a good drug because it causes less serious stomach problems, and it does increase the risk of heart attacks, but not for people who don't have a previous history of heart disease. Well, the truth is, Merck knew about 6 months earlier, and the FDA knew at the time, that Vioxx causes significantly more heart attacks, blood clots, and strokes for people than naproxen or Aleve, whether or not they have a previous history, and that overall, Vioxx is a significantly more dangerous drug than Aleve. They knew that, but it didn't appear in the New England Journal of Medicine's article. And then there was a review article that appeared in the New England Journal of Medicine in August of 2001, and it said these cardiovascular problems may be due to the play of chance, is the language that was used, play of chance. The play of chance the FDA had identified 7 months earlier as between 1 in 1,000 and 1 in 10,000. But the review article said it would play a chance. 13 out of 13 of the authors of the original research article had financial ties to Merck, and 2 out of 2 of the authors of the review article had financial ties to Merck. Then there's clinical practice guidelines. Now, we docs may not be as smart as you think we are, but we sure know how to get good grades. And when those clinical guidelines are published, it creates a real imperative for us practicing doctors to follow them, because that's how we get measured about the quality of our care. That's evidence-based medicine. You've all heard evidence-based medicine. That's how we're going to solve the problems in our healthcare system, by practicing evidence-based medicine. Well, the guidelines were published by the American College of Rheumatology, which is the nonprofit professional society of arthritis specialists, in September of 2000. And they said after non-pharmacological measures like heat and ice and stretching and exercise, which are very important, doctors should try acetaminophen or Tylenol, and after that they should try a COX-2 inhibitor, meaning Celebrex or Vioxx. There are four authors of these guidelines, and three of the four authors had financial ties to Merck, and 3 to the company that makes Celebrex. So the point that I'm making here is that the fundamental lesion, as we say in medicine, is that there's been a transformation of our medical knowledge that even the best docs have to trust, from a public good to a private good. But it still looks like a public good, and that's why we're not making progress. That's the message that I want to leave here, is that when these articles, even though they're sponsored by the drug companies, even though they're written by authors who predominantly have ties to the drug companies, even though many of the authors don't get to see all the data, nonetheless, these articles are accepted as true when they're published in our respected journals. And yet these articles have a singular purpose when they're sponsored by commercial sources. The responsibility of the commercial sources is to maximize their return on investment. And I don't fault the drug companies for that. Just like any company that makes any product, their responsibility is to their shareholders. So it's the context in which this is unfolding. If we're going to have a society that works, there needs to be a balance so that the corporations can only make profits when they provide commensurate social value, and that's what's out of sync here. Now, it's true wherever you look. We don't have enough time. How much more time do we have, George? 5 minutes? 15 minutes. Okay. Well, let me tell you about cholesterol-lowering drugs, because everyone knows the answer about Vioxx. But let me tell you about the cholesterol-lowering drugs, the statin drugs, and I'm sure many people here are on cholesterol-lowering drugs. In 2000, Americans were taking twice as many cholesterol-lowering drugs as people in Europe at the same level of risk of heart disease. Twice as many. And we were getting 3 times as many procedures done to open up our blocked arteries. So you would say, well, that's high-quality care. You know, that's what we're paying for. Our coronary heart disease death rate ranked 19th among industrialized countries, and we were losing ground to most of them. So we're more statins, more procedures, we ranked 19th, and we're losing ground. Now, right, the real problem here is that we didn't obey the first rule of holes, because when you're in a hole, the first thing you should do is stop digging. But But we dug much harder because the National Cholesterol Education Program, which comes out of the National Heart, Lung, and Blood Institute, which is part of the National Institutes of Health, came out with an updated cholesterol guideline in 2001 that said we should increase the number of Americans taking cholesterol-lowering drugs from 13 million to 36 million. And most of the people in that increase are people who don't yet have heart disease but are at risk of getting heart disease. So what's the evidence? They say, well, for women, they cite 6 studies to show that women who don't have heart disease will benefit by, who are at elevated risk of heart disease. 6 studies are cited to show that the women will develop less heart disease if they take a statin. But 5 of the studies are from people who already have heart disease, and 1 study had so few women that there were only 20 cardiac events, and it was nowhere near statistically significant. And later on at the back of this 284-page document, it says, well, evidence for women is, quote, generally lacking. And they extrapolate the results from men. Now, this is after the hormone replacement debacle, after we found out that hormone replacement therapy, which we, quote, knew reduced heart disease because it improved cholesterol, didn't. Extrapolated from men. And then they go on to people over 65, and they cite 9 studies showing how statin drugs benefit people who are over 65, but none of the 9 studies show that. There's no significant evidence. Then we get to the update in 2004, written by 9 people, published in the journal Circulation, the Journal of the American Heart Association, which says, well, it was 36 million people at moderate risk or higher, but we're going to lower the trigger for starting a statin drug from 130 LDL down to 100. Now, only 1/6 of Americans, adult Americans, have an LDL of 100. So we're going to add millions more people. On the basis of what evidence? Well, there was a study that looked at the effect of Lipitor on women who have hypertension and at least 3 other risk factors for heart disease. Half the women got Lipitor, half the women got a placebo. The women who took Lipitor had 10% more heart attacks. More heart attacks. That's not very good evidence for lowering the threshold for starting Lipitor. We had a study that looked at elderly folks. The new guidelines said clearly people over 65 who don't have heart disease, who are at risk of heart disease, benefit from taking a statin drug. The PROSPER study, published in The Lancet, is one of the studies that they drew from. The PROSPER study looked at people aged 70 to 82. Those people who didn't have heart disease got no benefit from taking a statin. But they did get more cancer, significantly more cancer. And this is an issue that it's kind of forbidden to talk about this issue. But Table 4 of the PROSPER study in The Lancet, which is the most important British medical journal, shows that people over age 70 who take statins get more cancer, statistically 25% more cancer over 4 years than the people who don't take a statin drug, and this risk gets higher in each of the 4 years, which is what we look at when we think there may be a significant finding. If the trend progresses in the direction that you would expect if it were true, that doesn't prove that it's true, but it suggests it's true. The people who favor using more statins say, well, that's just one study, and the other studies don't show that. That's very true. But the other studies, the average age is about 60 years old instead of 75 or 76 in the PROSPER study. And it may well be that older folks are more vulnerable to cancer-causing properties of statins than younger folks. So it looks, at least it's possible, that this study shows, it's like a sentinel canary, that this study is the first demonstration that we have of this problem. And it reminds me of 1989. In 1989, when we got the first study that showed that hormone replacement therapy increases women's risk of breast cancer. Well, that got blown off because everyone knew that hormone replacement therapy was better for you, and the risk of breast cancer was tolerable. Well, there were probably 400,000 extra cases of breast cancer because we didn't pay attention to that. A study in Britain showed there were 100,000 in Britain, and we have a much bigger population, and we had many more women on hormone replacement therapy. So we're ignoring this study. Now, the good news is very good, because even though there's been this commercial takeover of what we consider to be our valid medical knowledge, so that what we think and what our doctors think is good medical care gets focused on the cholesterol and on pills. The good news is that what we're not hearing in the headlines really should be headlines. The Nurses' Health Study shows that women who exercise routinely, eat a healthy diet, don't smoke, drink in moderation, and have a reasonable body weight reduce their risk of heart disease by 83%. Risk of diabetes by 91%. People over 65 who do the first four things, exercise, eat a healthy diet, don't smoke and drink in moderation, their death rate is 60% lower than the people who don't do those four things. But cholesterol-lowering statin drugs don't change their death rate. So this should be the news. The problem is that when we have all this advertising, the amount of money we're spending on drug advertising to consumers has gone up 75 times since 1991. We're the only country that allows direct-to-consumer advertising besides New Zealand. When you have all this direct-to-consumer advertising, when the research is being done, about 80% of the clinical research by the drug companies, when the guidelines are dominated by people with financial ties to the drug companies, and this last iteration of the cholesterol guidelines, there were no conflicts of interest mentioned in Circulation, the Journal of the American Heart Association, but 8 out of the 9 experts had financial ties to the drug companies. And the expert who had the most ties to the drug companies is a full-time employee of the National Institutes of Health who oversees the guidelines and received $114,000 in consulting fees from the statin makers between 2001 and 2003. So what we've got is that what we think is the best medicine is the most profitable medicine. And in that sense, our healthcare system is designed perfectly to generate the maximum return on investment. But it's designed very poorly to produce the best health most effectively. Now, these issues, I thank you for listening to me. These issues are hard to communicate. It's hard to get it across because you've got to swim against this commercial current to get these ideas out. It's very hard. I mean, this has got to be like a political movement to start to get to these ideas. Next week, you're going to be hearing, I guess, about universal health care. And my God, we need universal health care. What an embarrassment that the United States is the only country that doesn't have universal health care. It could be socialized medicine. It could be run by the government like Medicare. It could be a mosaic of private and public funding. How you fund it, I don't know. But that we need to cover everybody, of course we need to cover everybody. But I don't think that we can have universal health care until we get the knowledge, our medical knowledge, straightened out. Because we're just going to be spending more and more money. We're spending this extra $500 billion on health care that is either neutral or harmful to our health. The researchers from Dartmouth Medical School looked at the Medicare spending across this country. And they find that there's a 60% variation in spending from the lowest spending regions to the highest spending regions. But in the lowest spending regions, the quality is no less, the satisfaction is no less, the patient preference care is no less, meaning women who have breast cancer having lumpectomies or mastectomies, and men having prostatectomies or radiation or hormone therapy. The care is no worse in the lower spending regions, and actually the mortality rate is 2 to 5% higher in the higher spending regions. Health Affairs just had a graph, it just published a graph. It had a quality ranking on one side, so the states were ranked from 1 to 51 with Puerto Rico. So the highest quality is up here, lowest quality down here, and the amount of money that's spent is here. And the line, you would think, as the amount of money you spend goes up, the quality would go up, and it goes exactly the other way. The more money that's spent in a state, the lower the quality of care. So these problems need to be solved, or we're not going to be able to afford universal health care because we're just going to be buying bad, expensive health care for everybody. So I hope that we can, as we move forward, I hope we can address this urgent issue of making sure that every American has access to decent health care at an affordable price. They don't have to go to a charity clinic. That every American has a right to get good health care, and we need to straighten out our medical knowledge so that the primary function of our medical knowledge is to improve our health and to teach us how to live healthy lives, because 70% of our health is determined by how we live our own lives. That's the good news. Most of health care is in our own hands. The other 30%, I'm very grateful that we've got medical care that is the best in the world when we need that high-tech medicine. And I just had surgery here 3 weeks ago And I'm very grateful that the surgeon was skilled, that the hospital had the right equipment. So thankful for the medicine we have, but we have a long way to go to get our medical care up to the quality we expect and to make it available to all Americans. Thank you.
Dr. John, Mr. Collins and I will ask you some questions, but just because we had the recent congressional baseball season, congressional hearings on steroid use, do you have a view about that?
I do. Some people say, hey, just let the drugs go on because that's the way it happens and you can't police it. I don't agree with that at all, George. I think that this is just an awful example that we're setting for our children. And in some ways, an extension of what I'm talking about, the transformation of medical knowledge. I mean, have we turned our sports into such a commodity that people are willing to sacrifice their bodies to be successful at it? And is this the ideal that we want our children to see? To think that instead of getting out there and practicing and working hard and getting in shape, they can take pills and succeed? I don't think so, George. I think it's just a terrible example.
Doctor, another question along that line. Our children are probably the most over-medicated generation of children ever. What can we do to get our children away from this medication example that we have that tries to temper their behavior and makes them less healthy?
Oh, that's a great question. I just got an email from my website, I think yesterday, that said, thank you for writing the book. Now will you write Overdosed American Jr.? The same subject. I think the use of stimulant medication and antidepressants in children is just so out of control. I mean, our kids want to run around, they want to have fun, they don't want to pay attention all the time. And what we've done is we've created boxes, square boxes that we want to put these round holes into, and they just don't fit. Maybe our students can talk about this issue a little bit. But I was heartbroken. I gave a talk at the New York City Health Department about statins. They wanted to make guidelines, and they understood that there were serious problems, and they wanted to hear a longer version of what I told you about the problems with the cholesterol-lowering drugs. And there was a woman who was just about in tears. She is passionate about physical education and getting kids to run around and run off that steam and feel good about their bodies and athleticism. She said physical education is getting cut out, but they have to spend the money to put defibrillators in every school. So I mean, I think we've just got the wrong attitude here. I mean, kids are kids, and my God, you know, the most important thing for a child to learn in school is that that child's a good person, and that that child can grow up and have fun in the world and be a responsible citizen and a good adult. And I think if we get back to that idea, we're going to do a lot. And drugging, you know, there are some kids that need to be drugged. I mean, you get to spot them once you become a seasoned physician. I mean, you can have a child brought into your office, and in 3 minutes, your office can look like a cyclone hit it. Every cabinet emptied, everything spilled and broken, and you know that kid is tortured. That you know that child, when that child's in school, feels terrible about himself or herself. Well, that, I think, is a virtual emergency. You got to get that child to start to feel good about him or herself, because if they don't and they get that negative self-image and they become a clown or they get their ego gratification from being negative and behaving poorly, that's very hard to undo. So that we've got to treat. But this idea that some, you know, double-digit percentage of our children need medicine, I think we're just spitting in Mother Nature's face, and we're not listening.